Anesthesia Rounds, a series of discussions of clinical problems facing the anesthesiologist. Anesthesia Rounds is presented as a service to clinicians in the field of anesthesiology by Ayerst Laboratories. In this interview, Dr. John J. Downs, Senior Anesthesiologist and Director, Intensive Care Unit, Children's Hospital of Philadelphia, discusses the clinical and physiologic criteria associated with the diagnosis of acute respiratory failure in infants and children. Among the topics that Dr. Downs will consider are the general definition of acute respiratory failure, diseases characteristic of the several pediatric age groups, and the various criteria he uses for diagnosing acute failure in specific diseases and groups of diseases. Dr. Downs, what is your definition of acute respiratory failure?
To some physicians who are concerned with the management of pulmonary disease, particularly chronic pulmonary disease, respiratory failure means any condition that results in an increased arterial PCO2. But to most anesthesiologists, respiratory failure is a condition in which there may be not only an increase in arterial PCO2, but more importantly, one in which the patient no longer can perform the respiratory work required to achieve adequate gas exchange at the tissue level. This patient is in imminent danger of losing his life unless someone intervenes, usually by inserting an artificial airway and attaching it to a mechanical ventilator. Thus, the difference in definitions of respiratory failure has considerable therapeutic importance. Different usage of the term has led to disagreement between groups of physicians regarding the treatment of respiratory failure, whereas the disagreement actually centered around the definition of respiratory failure.
Are blood gas measurements sufficient to define respiratory failure?
No, I don't think so. In addition to the absolute levels of arterial PCO2 and PO2, the following must be considered. First, the underlying major disease process, which may be pulmonary, cardiovascular, neurologic, or metabolic. Whether this is an acute or chronic disease, whether there is some form of physiologic compensation or no compensation. Secondly, the past history of the patient's ability to cope with major physiologic stress is important. Third, the duration of the present acute illness and history of the patient's response to therapy can be important to the outcome of the management of respiratory failure. Fourth, the direction and rate of change in blood gas tensions, the alveolar arterial oxygen tension gradient, the arterial pH, minute volume, and the vital capacity. All these factors should be considered when determining whether a patient's life is in immediate danger. However, the arterial blood gas tensions are readily available and remain the most important guide to the adequacy of pulmonary and tissue gas exchange.
Dr. Downs, are there general objective criteria for respiratory failure in the pediatric patient?
No, there are not general criteria. The criteria must be defined for each group of diseases and occasionally for individual diseases within a large group. For example, we have learned from clinical experience that a child suffering from an acute progressive polyneuritis, such as the Guillain-Barré syndrome, whose vital capacity has fallen to less than twice his predicted tidal volume being approximately 6 milliliters per kilogram, this child will soon develop widespread atelectasis, aspiration pneumonia, and hypercapnia. Therefore, even in the presence of a normal arterial PCO2, we regard such a reduced vital capacity to be indicative of acute respiratory failure in children with polyneuritis. In such instances, we proceed with tracheostomy and mechanical ventilation.
Well, doctor, in what disease setting would arterial PCO2 be of major importance?
In a child with status asthmaticus, an arterial PCO2 that remains over 75 millimeters reflects an alveolar ventilation that may not be consistent with survival without mechanical ventilation. Therefore, we rely in this particular disease on arterial PCO2 as a major criterion.
What is the practical significance of a diagnosis of respiratory failure?
I think if the term acute respiratory failure is to have practical meaning, it must call for a specific plan to support a vital system that has failed. In most instances, this will mean insertion of an artificial airway and assisted or controlled mechanical ventilation.
Now, what are some common causes of respiratory failure and their criteria in the newborn?
Among the various pulmonary diseases causing respiratory failure in the newborn, the most common is the idiopathic respiratory distress syndrome, so-called hyaline disease, for which we use the term RDS. This disease accounts for more than 25,000 deaths and an untold morbidity each year in the United States alone. The lower the birth weight, the higher the mortality. The initial diagnosis can usually be made on the basis of clinical signs and a chest X-ray to exclude other causes of respiratory distress. We have organized our clinical evaluation into a scoring system that assigns a score of 0, 1, or 2 to each of 5 clinical observations, which are cyanosis, retractions, grunting, air entry, and respiratory rate. We think that a value of 4 or more indicates the presence of RDS. A score of 7 or more suggests impending or indeed existing respiratory failure and is associated with a mortality exceeding 60%. Our criteria for respiratory failure have been utilized in some 180 infants. Now, among the infants that we have studied, we have observed also certain signs of respiratory failure that are associated with nearly 100% mortality if mechanical ventilation is not employed. These criteria consist of apneic episodes, an arterial PCO2 equal to or over 75 millimeters, and an arterial PO2 less than 50 millimeters in 100% oxygen. If 2 or more of these signs are present, we proceed with tracheal intubation and mechanical ventilation.
Well, Dr. Downs, what variations in criteria occur with surgical diseases of the newborn?
Newborn infants incurring severe asphyxia from congenital diaphragmatic hernia and pulmonary hypoplasia in the first 24 hours after birth also require tracheal intubation and controlled ventilation both before and after surgical repair. If one waits until the arterial PCO2 exceeds 75 millimeters of mercury after repair before instituting mechanical ventilation, the likelihood is that the infant will die before respiratory failure is recognized. For this reason, we routinely employ nasotracheal intubation and mechanical ventilation for 1 to 2 weeks after operation. Bilateral thoracotomy tubes are also inserted as prophylaxis against pneumothorax. Following other operative procedures in the newborn, our criteria of respiratory failure are even less definite. In these patients, we would consider an arterial PO2 less than 100 millimeters in 100% oxygen, or an arterial PCO2 over 55 millimeters, indicative of impending or existing respiratory failure. Among newborns with cyanotic congenital heart disease receiving palliative surgery to improve their arterial oxygen content, we have observed no survivors whose postoperative arterial PO2 was less than 30 millimeters in 100% oxygen, unless they received mechanical ventilation for a period of days or weeks. In these infants, extreme hypercapnia, a PCO2 over 75 millimeters, does not occur until just prior to death.
Are there causes of respiratory failure in the newborn other than cardiopulmonary diseases?
Yes, the most common extrapulmonary cause of respiratory failure in the newborn is central nervous system impairment resulting in apnea. This occurs most often in infants less than 1,500 grams birth weight. Apneic episodes last more than 10 seconds result in severe hypoxemia and hypercapnia, and require stimulation or positive pressure ventilation with bag and mask before spontaneous ventilation resumes. This differs from periodic breathing, in which the apneic phase lasts less than 10 seconds, pulmonary gas exchange is not impaired, and breathing resumes spontaneously. Apneic episodes may be associated with hypothermia, hypoglycemia, intracranial bleeding, and neonatal sepsis. But unfortunately, in most cases, no definite cause can be determined. When, after what appropriate treatment is possible has been rendered, an infant has more than 2 apneic episodes per hour, or if spontaneous ventilation does not promptly return with bag and mask positive pressure oxygen, we think respiratory failure exists and continuous mechanical ventilation is indicated. Waiting for the blood gas tension values used in the diagnosis of respiratory failure in RDS will be disastrous in this group of infants.
Dr. Downs, what about the criteria for acute failure in the older infant?
Again, these will vary in the type of disease. In infants and children over 1 month of age with acute pulmonary disease, we look for the following clinical criteria: decreased or absent inspiratory breath sounds, severe inspiratory retractions and use of accessory muscles, cyanosis in 40% oxygen, depressed level of consciousness and response to pain, and poor skeletal muscle tone. At the same time, we try to obtain physiologic information. Our criteria are the following: an arterial PCO2 equal to or greater than 75 millimeters, an arterial PO2 less than 100 millimeters in 100% oxygen, and a physiologic dead space to tidal volume ratio greater than 0.75, which is to say a physiologic dead space greater than 75% of tidal volume. Now, if an infant has any 3 of our clinical criteria and 1 of these physiologic criteria, we think this justifies the diagnosis of acute respiratory failure.
And Dr. Downs, what is an example of this?
One disease entity we encounter frequently is bronchiolitis, which is really a viral bronchopneumonia. This disease produces bronchial obstruction and alveolar hypoventilation because of edema, smooth muscle spasm, and secretions in the bronchi and bronchioles. It affects children anywhere from 1 month to 24 months of age. Although the mortality is quite low, death can occur even in the otherwise healthy infant. Therefore, we undertook arterial blood gas and pulmonary function studies during a 2 to 3 year period in which we encountered a large number of cases.
And what were the results?
What we found was rather interesting. The infants were obviously hyperventilating. Minute volumes were 2 to 3.5 times the predicted volume, and physiologic dead space was indeed increased. We obtained reasonably accurate studies of 5 babies who had severe bronchiolitis, only 1 of whom met our clinical criteria for acute respiratory failure. Now, the normal VD-VT ratio is approximately 0.3 in infants. In the babies with bronchiolitis, the VD-VT ratios varied from 0.55 to 0.76, the latter number being associated with the 1 baby who did have acute respiratory failure.
How did changes in the VD-VT ratio affect the arterial PCO2?
Now, we looked at the relationship of PCO2 to the VD-VT ratio. And we saw that the infant with a VD-VT ratio of 0.55 had a PCO2 within the normal range. But his minute volume was increased almost 300%. In other words, he was maintaining his alveolar ventilation at an enormous energy expenditure because there was considerable increase in airways resistance and work of breathing. Now, the baby who had the very high VD-VT ratio, 0.76, also had a PCO2 of 70 millimeters, a level we consider indicative of respiratory failure. This baby had a minute volume nearly equal to his predicted minute volume. He was moving only the normal volume of gas in and out of his lungs each minute. However, he was in impending respiratory failure because over 3/4 of every breath was wasted.
Then minute volume or blood gas measurement alone could be quite misleading here?
Yes, at least in bronchiolitis, measurement of minute volume alone is not of very much help. But in conjunction with arterial PCO2, and in addition a VD-VT ratio, we can put together a fairly coherent picture of what's happening. In severe bronchiolitis, the volume of physiologic dead space is nearly doubled. And to overcome this and maintain arterial PCO2 values under 50 millimeters, the infant must maintain a minute volume of 200 to 300% of his predicted normal. Against the increased airways resistance inherent in this disease, this is eventually going to lead to fatigue, particularly since the babies are not able to eat and therefore have caloric deprivation. What usually happens is that pulmonary function gradually improves, and in 24 to 48 hours, the physiologic dead space decreases with a VD-VT ratio less than 0.5. The baby can cope with this. But in a small number of infants, improvement does not occur, and fatigue with subsequent respiratory failure results.
Dr. Downs, can you provide a case example of respiratory failure in bronchiolitis?
I think a fairly typical example is provided by the case of an 18-month-old infant weighing about 10 kilograms. This baby presented with gasping, shallow respirations, tachypnea, retractions, very poor inspiratory breath sounds, and no visible response to needle injections or other stimuli. His arterial PCO2 was 100 millimeters and pH 7.07. After bag and mask oxygen and intravenous sodium bicarbonate, tracheal intubation, intravenous curare, and constant volume mechanical ventilation resulted in a gradual reduction in arterial PCO2 to 50 millimeters within 12 hours. The airway pressures reached during this period were in the range of 50 to 55 centimeters of water. After some 3 days, the wheezing became minimal, and adequate alveolar ventilation could be provided with airway pressures less than 25 centimeters of water. Following reversal of his myoneural blockade, the infant's spontaneous unassisted ventilation resulted in an arterial PCO2 of 42 millimeters. Uneventful recovery followed in the subsequent 5 days.
Dr. Downs, do infants with congenital heart disease develop respiratory failure?
Infants with cardiovascular lesions requiring immediate surgery, whether it be palliative surgery or corrective surgery, commonly develop acute respiratory failure. This may occur before or after operation. Among this group, the patients with severe pulmonary arterial hypertension, that is a mean pulmonary artery pressure equal to or greater than 75% of mean systemic arterial pressure, are particularly prone to respiratory failure. Thick, copious bronchial secretions, recurrent atelectasis, and increased ventilatory effort, probably due to decreased lung compliance, are the major clinical signs. These usually appear in conjunction with a VD-VT ratio of 0.5 or more, a larger alveolar arterial oxygen tension gradient than would be anticipated from the cardiac lesion itself, and mild to severe hypercapnia. Our general criteria for respiratory failure in infants with severe congenital heart disease differ somewhat from those used for acute pulmonary disease.
What are the criteria?
We look for the following clinical criteria: severe retractions, apnea or gasping in 100% oxygen, decreased to absent inspiratory breath sounds, expiratory grunting, tachypnea, and arterial hypotension or bradycardia. Among the physiologic variables that we look to for help are the arterial oxygen tension. Here, if this is below 30 millimeters of mercury and 100% oxygen in children with cyanotic lesions, or below 75 millimeters in 100% oxygen in children with acyanotic lesions, we think respiratory failure may be imminent. An arterial PCO2 over 50 millimeters and a VDVT ratio over 0.5 infer that respiratory failure is developing. And as previously mentioned, a mean pulmonary artery pressure equal to or greater than 75% of mean aortic pressure is indicative of severe pulmonary arterial hypertension that may lead to respiratory failure. Now, these criteria cannot be made more specific without further detailed ventilatory studies of infants with the various common anomalies. However, they serve as a guide to the treatment of the infant who undergoes surgery for congenital heart disease within the first 2 years of life.
Doctor, are there causes of respiratory failure in the older infant other than cardiopulmonary diseases?
Yes, very definitely. Sepsis, particularly that associated with infection by gram-negative bacteria, can cause acute respiratory failure. The pathogenesis of respiratory failure in sepsis is poorly understood at this time, but appears to be associated with a large alveolar arterial oxygen tension gradient, increased ventilatory effort, and, at least initially, a large minute volume. Reasonable criteria for instituting mechanical ventilation in septic infants have yet to be developed.
Doctor, what other etiologic factors may be involved?
Among the other extrapulmonary causes of respiratory failure in infancy, upper airway obstruction due to severe laryngotracheitis, or croup, and foreign body aspiration are common. However, to my knowledge, no systematic evaluation of criteria for intervention with tracheostomy has been developed. Poisoning due to ingestion of drugs or toxic household products is a leading cause of death in infants between 1 and 2 years of age. Many of these babies die of acute respiratory failure associated with coma, convulsions, hyperpyrexia, or secondary aspiration pneumonitis. Again, clinical and physiologic criteria have not been developed, except that in the stuporous infant, a crying vital capacity less than twice the predicted tidal volume certainly warrants mechanical ventilation, provided that the infant responds sufficiently to provide a crying vital capacity. And an arterial PCO2 over 50 millimeters probably signifies impending respiratory failure and warrants tracheal intubation and mechanical ventilation.
Doctor, what about the criteria of respiratory failure in the child over 2 years of age?
In children with acute pulmonary disease and congenital heart disease, we employ the same criteria we previously discussed for infants less than 2 years of age. For example, we have found that the pathophysiology of respiratory failure in status asthmaticus and bronchiolitis to be quite similar. The clinical and physiologic criteria of respiratory failure in both diseases are also similar.
Could you elaborate a bit on the pathophysiology of respiratory failure in children with status asthmaticus, Doctor?
First, let us define status asthmaticus. This term refers to a condition of intense bilateral bronchospasm in an asthmatic child, which is not improved by 2 subcutaneous injections of epinephrine in a dose of 0.01 milligrams per kilogram. Engström in Sweden has shown that the acute asthmatic episode in a child is associated with a marked increase in airways resistance, decreased lung compliance, and a minute volume which is increased considerably. The net effect, of course, is a substantial increase in the work of breathing. Now, in our studies of 18 children with an average age of 5 years who were admitted to the hospital with status asthmaticus, we observed the expected direct relation of arterial PCO2 and the VD-VT ratio. Minute volume was also increased, between 150 and 350% above predicted normal levels in those children who were able to maintain an arterial PCO2 under 45 millimeters. When the minute volume fell to less than 150% of predicted in the presence of a VDVT ratio over 0.75, the arterial PCO2 exceeded 75 millimeters and signs of acute respiratory failure developed. Respiratory failure was averted in one case by a decrease in physiologic dead space through an improvement in the bronchomotor tone with isoproterenol. In another case, mechanical ventilation was required to provide a minute volume sufficient to compensate for the very large physiologic dead space. The fall in minute volume resulting in respiratory failure probably can be attributed to fatigue, which is secondary to the very great muscular work demanded to maintain an adequate minute volume.
Now, Doctor, can you give us a case example of a child with respiratory failure due to status asthmaticus?
A fairly typical case is that of a 7-year-old child with severe chronic asthma requiring continuous corticosteroid administration. She was admitted to the hospital, stuporous, with very poor inspiratory breath sounds, both inspiratory and expiratory wheezing, and no response to painful stimuli. The arterial PCO2 was 170 millimeters with a pH of 6.88 after 25 milliequivalents of sodium bicarbonate intravenously. Following tracheal intubation and mechanical ventilation with a constant volume ventilator for 3 hours, the arterial PCO2 was 90 millimeters, and the child began to cough and awaken. She became out of phase with the ventilator. Chlorpromazine and meperidine given intravenously provided sufficient sedation to permit effective controlled ventilation. 24 hours after admission, wheezing became minimal, and the child maintained an arterial PCO2 less than 50 millimeters with unassisted spontaneous breathing. Her uneventful recovery followed.
Have criteria been developed for the diagnosis of respiratory failure in children over 2 years of age with non-cardiopulmonary diseases?
To a very limited extent. For example, in the child with infectious polyneuritis or the Guillain-Barré syndrome, we regard a vital capacity less than twice the predicted tidal volume, which is approximately 6 ml per kilogram, to be indicative of impending respiratory failure. An arterial PCO2 over 45 millimeters or an arterial PO2 less than 70 millimeters during air breathing indicate existing respiratory failure in these patients and, I think, warrant immediate tracheal intubation and controlled or assisted ventilation. To my knowledge, no systematic criteria of respiratory failure exist for other problems, such as severe thoracic injuries, kyphoscoliosis, renal failure, dermatomyositis, and other entities that can produce respiratory failure or failure of pulmonary gas exchange.
Now, Doctor, what has prompted the current great interest in the diagnosis and management of respiratory failure in children?
Well, first, respiratory failure is a major cause of death in infants and children, and yet the excellent prognosis for most children, if they can be supported during the immediate crisis, I think explains the basic interest among physicians. In pediatrics, proper diagnosis and management of any organ system failure promises not a year or two, but a lifetime of useful living. And then the increased capacity to gain objective data through blood gas analyses and pulmonary function studies, for instance, our increasing ability to alter the course of events, such as with mechanical ventilation, and the accumulation of clinical knowledge that has occurred in recent years have radically improved the chances for success. I don't think that better equipment will be the sole factor in further improving our results. Rather, I think that the increased utilization of experienced, organized teams employing intelligent, vigorous approach in regional referral centers reached by the pediatrician or general practitioner through clearly marked channels could be a major factor in the survival of many children in the near future.
Thank you very much, Dr. Downs, for a most useful discussion. Anesthesia Rounds is presented as a service to clinicians in the field of anesthesiology by Airst Laboratories. Anesthesia Rounds, a series of discussions of clinical problems facing anesthesiologists. Anesthesia Rounds is presented to clinicians in the field of anesthesiology by Airst Laboratories. In this interview, Dr. Leonard W. Fabian, Professor and Chairman, Department of Anesthesiology, University of Mississippi, School of Medicine, Jackson, discusses the anesthetic management of shock. Among the topics he considers are the signs and symptoms of shock, circulatory, cellular, and metabolic alterations, safe management of hemorrhagic and septic shock during anesthesia, tolerable blood loss and fluid replacement, and the use of vasoactive drugs. Dr. Fabian, how does the anesthesiologist identify preoperatively the patient with clinical shock?
The symptoms and signs presented by the patient in shock should be well known to all physicians. Typically, for the patient in moderate or deep shock, one observes cold, clammy skin, restlessness, hypotension, tachycardia, a low central venous pressure, oliguria, hypothermia, and a low voltage electrocardiogram.
What is meant by spinal shock?
This term refers to neurogenic shock, in which there is profound peripheral vasodilatation as a result of sympathetic paralysis. This might occur, for example, following spinal cord trauma or accidental total spinal anesthesia.
What is irreversible shock? What happens to the microcirculation in this condition?
By definition, the term irreversible shock means that as a result of extensive cellular damage, there is progression to death in spite of all therapeutic measures. Associated here is the concept that the microcirculation is disrupted and incapable of responding to therapy in any manner.
What changes are caused by shock at the cellular level?
The primary problem is, of course, hypoxia. Because of the deficiency in oxygen uptake, there is interference with general cellular metabolism. The mechanisms involved here include reduction in carbohydrate oxidation, increases in protein breakdown, and alterations in all the important media that control acid-base balance.
What are the metabolic effects of shock?
Oxygen consumption and body temperature are reduced significantly. Liver glycogen and blood sugar tend to show an early increase, but they decrease as shock progresses. Depending on the severity of shock, the lactate-pyruvate ratio is significantly increased, primarily as a result of excess lactate. Azotemia occurs with the breakdown in body protein, as does a significant metabolic and perhaps respiratory acidosis.
What about electrolytes and plasma cortisol?
The electrolyte content also shows remarkable alterations. There is a decrease in serum sodium and chloride, an increase in serum potassium, and a low intracellular water. Along the same lines, a significant decrease in blood levels of the various vitamins has also been noted. ACTH and adrenal, cortical, and medullary secretions are generally increased, and their serum levels tend to rise as shock progresses. The significance of all these metabolic alterations is, of course, that they reflect the presence of severe cellular damage and the efforts of the body to compensate for damage. As for other cellular effects of shock, there has been a great deal of work on energy compounds such as ATP. Studies on the mitochondria are progressing at a rapid rate, but have in general produced no definitive results.
What is sludging and how does it affect the course of shock?
The term sludging refers to the tendency of red blood cells to aggregate as a result of slowed flow through the capillary beds. Clots may form in the capillary areas, leading perhaps to the production of small emboli.
How much blood loss can be tolerated before shock appears in an otherwise healthy subject?
Here again there has been a considerable amount of investigation on this subject, and Simeon has discussed some of the results obtained by studying patients in World War I and World War II. It is rather amazing that the blood volume deficiencies which were noted to produce given degrees of shock are remarkably similar in the two series. For example, it was observed that in the previously normal 70-kilogram male, an acute blood loss of 1,000 milliliters was tolerated reasonably well, and compensation was generally adequate without replacement of this lost blood volume. However, losses in excess of 1,000 milliliters were associated with moderately severe shock requiring replacement therapy. Failure to replace blood volume when losses were above 40% of initial blood volume was and is generally associated with irreversible shock.
What replacement fluids do you favor and how much do you give?
The treatment of acute blood loss is, of course, replacement of whatever volume is necessary to correct the hemodynamic alterations I have mentioned. Although quite a general statement to make, I feel strongly that in replacement therapy, one should attempt to replace specifically those fluids that have been lost. If there has been whole blood lost, then replacement should be with whole blood. Similarly, in cases of severe dehydration without whole blood loss, replacement therapy should be directed toward repletion with the proper fluid and electrolyte. The latter therapy is, of course, based on the general clinical appearance of the patient, the past history, and whatever information we may glean from laboratory determinations. How much a patient may need in the way of replacement varies considerably. For instance, considerable research has been done on the question of fluid loss in various body compartments and the suitability of infusing large amounts of lactated Ringer's solution as a general replacement fluid. I certainly subscribe in principle to this approach and the concept behind it, but surely it can be overdone with resulting circulatory overload.
What vital signs do you monitor in the patient whom you consider to be in shock and why?
Our monitoring serves to provide guidelines to the amount of fluid replacement necessary in a given patient. I believe we must correlate closely the levels of arterial blood pressure, central venous pressure, and urinary output with the general clinical appearance of the patient. The electrocardiogram is also useful as a monitoring tool. As shock progresses, we frequently observe a lowering of the voltage on the electrocardiogram and the presence of certain arrhythmias.
Are there any bedside tests safe for the shock patient that help determine impairment of vital functions?
Perhaps the basis of bedside diagnosis, if you will, is gross observation of the patient's clinical appearance. Unfortunately, many individuals rely too heavily on arterial blood or central venous pressure reading as an index to total therapy. These parameters are sometimes quite misleading. Among others, the so-called tilt test has been employed, and here the patient's body position is adjusted rapidly in order to ascertain whether hypotension of significant degree will occur. Pulmonary ventilation may be determined in a simple way by the use of an instrument such as the right respirometer, and in a more fundamental way by measurement of arterial blood gases. Cardiac depression is reflected, of course, in decreased arterial pressure and perhaps in this instance, increased venous pressure. The electrocardiogram may also be of some value in this area. A great deal can be learned by the old, reliable, simple palpation of the pulse to monitor the heart rate and get some idea of the pulse volume. A rapid pulse rate and a thready pulse are always strong indications of a shock-like state. We have already mentioned the importance of urinary output with respect to the other factors used as diagnostic criteria.
How do you correlate measurements of hemoglobin, hematocrit, and circulating blood volume?
I would like to emphasize the importance of associating all these parameters. For example, to treat the patient in shock on the basis of a hemoglobin or hematocrit determination is not only useless, but fraught with danger. The severely dehydrated patient may actually have a, quote, normal, unquote, hemoglobin and hematocrit. He may even be severely anemic. This confusion results from the hemoconcentration, of course. In my opinion, measurement of circulating blood volume in the patient who is bleeding has very little to offer. At best, the values for blood volume may be off by as much as 20 to 30%, even with the most sophisticated methods available. Only by correlating all the laboratory and mechanical determinations can we appreciate the true clinical status of the patient in shock.
Doctor, what underlying conditions other than acute blood loss may commonly cause shock before or during anesthesia, and how do you diagnose them?
Weil has outlined the general types of shock, which include hypovolemia, which includes hemorrhage, dehydration, and loss of protein. Secondly, cardiac failure, which includes myocardial infarction and cardiac dysrhythmias. Thirdly, bacteremia, such as in bacterial toxin shock or endotoxin shock, if you will. Fourth, hypersensitivity, which includes anaphylaxis, reaction to drugs, etc. Fifth, neurogenic shock, which is vasomotor paralysis, spinal shock, or cases of ganglionic blockade. A sixth category would be those general areas of impediment to blood flow, such as might be seen in pulmonary embolism or dissecting aneurysm. The seventh and final category of endocrine failure. This would be failures of adrenal cortex and adrenal medullary hormonal support. Differential diagnosis here is, of course, of utmost importance. Unfortunately, it is not too common for patients who have suffered acute myocardial infarction to be treated for other types of shock and to be lost as a result. Here again, I must emphasize the importance of associating all the differential diagnostic criteria that we have discussed, the need for obtaining historical information from the patient or his family, and the significance of clinical judgment based on general observation of the patient. The clinical pictures presented by patients in shock from a great variety of insults may be indistinguishable. For instance, the patient who has had a pulmonary embolus shows very little difference from one who may have suffered fat or air embolism. The patient with adrenal insufficiency may resemble or look exactly like the patient who is extremely dehydrated. A patient who was extremely dehydrated before a minor injury may appear identical to the patient who is in pure hemorrhagic shock. A word should be said about the rare but extremely dangerous entity of hypersensitivity, such as sensitivity to penicillin or certain insect stings. When a patient with this condition enters the emergency room in a state of shock, the situation is often extremely confused. A history from a friend or member of the family is therefore of the greatest importance in establishing a diagnosis.
What therapy should be initiated before inducing anesthesia for the patient in shock?
The most important aspect of pre-anesthetic therapy for the patient in shock has to do with the reestablishment of a circulating blood volume that is as close to normal as possible. All other measures are secondary. Concerning the administration of oxygen to a patient in shock, the breathing of room air will provide almost 100% saturation of the hemoglobin if the patient's ventilatory mechanisms are unimpaired. When a large amount of the red cell mass has been lost, the administration of 100% oxygen will elevate the plasma oxygen content approximately tenfold and provide a margin of safety.
Do you use morphine for the shock patient?
Morphine should probably be avoided except when severe pain accompanies the shock, and even then, low doses should be employed and intravenously.
What provisions do you make for fluid administration?
When one sees the patient in shock from any cause, the initial step in management should be the establishment of a route for intravenous infusions, whether percutaneously or by venous cut-down. The type and quantity of fluids to be administered are determined by the nature of the condition underlying the shock, but as an initial step, we prefer the early use of a lactated Ringer's solution while awaiting properly typed and cross-matched blood. With respect to the amount necessary, we employ the central venous pressure as one of our important guides in therapy, but not the only guide.
Are you concerned with temperature control of the patient?
There has always been some controversy in this area. The old adage of, quote, keeping the patient warm by piling on the blankets, unquote, probably provides erroneous advice for management. In fact, it is possible that the hypothermia accompanying shock may be a protective mechanism. Similarly, a controversy exists regarding the posture of patients in shock. There is little evidence to indicate that the head-down position is beneficial, and indeed there is considerable evidence to suggest that such a position may be detrimental because of ventilatory impairment.
Doctor, in what shock conditions are fresh blood, packed red cells, or Rh-negative blood necessary?
It is my strong opinion here again that we should replace what has been lost and nothing else. If the patient has a deficit of whole blood, he should receive whole blood. If, on the other hand, a patient is considered to have a normal or greater than normal blood volume, but is anemic, then packed red cells are of benefit. This is particularly true of patients who have severe heart conditions of any type. Although, in theory, O-negative blood should be safe, we must remember that there are a number of subtypes which may cause difficulty. I believe the administration of O-negative blood should be strictly reserved for the most dire bleeding emergencies. If there is time available, proper typing and matching should be performed.
Are there any dangers in giving plasma expanders?
Over the past several years, there has been some controversy concerning the usefulness of synthetic plasma expanders and the use of plasma substitutes or specific components of plasma. Solutions containing only fluids and electrolytes are of great value in situations where whole blood is not required. Here the patient suffers only from dehydration and loss of electrolyte, but has had no type of blood cell loss. Plasma expanders are not without hazard for two reasons. Solutions such as dextran, for example, may cause sensitivity reactions. Also, when such a solution is administered, it may interfere with accurate typing and matching of blood for the patient. The indication for plasma transfusion is a specific coagulation defect caused by a platelet deficiency. With respect to the use of pooled or even fresh plasma, we are always concerned, of course, with the possibility of inducing viral hepatitis.
When is intra-arterial transfusion of blood indicated?
A number of years ago, some investigators held that in cases of severe hemorrhagic shock, the intra-arterial transfusion of blood was of greater benefit than intravenous infusion because the blood would be placed directly into the outflow tract. This procedure is rarely, if ever, employed at the present time because most people feel that blood can be infused rapidly enough and in large enough quantities if the intravenous routes are available and large cannulae are used.
When is it necessary to give blood or fluid therapy by the bone marrow route?
I have never seen the necessity for intramedullary infusion of blood or fluids. If a percutaneous intravenous cannula cannot be placed, one can always perform a venous cut-down. In addition, the intramedullary route of administration is not without hazard, primarily because of possible infection.
When is it helpful to digitalize the patient in shock who requires prompt surgery?
Digitalization has been proposed as a therapeutic measure because cardiac failure may occur when shock reaches or nears the point of irreversibility. If, in the patient receiving large quantities of fluid, the arterial pressure remains low while the central venous pressure is rising sharply, digitalization may indeed be an effective measure.
Would you consider administering a vasoactive drug? And if so, which would you choose and why?
This brings us to the controversy of vasopressor versus vasodilator for the patient in shock. At the outset, I should mention that I am strongly opposed to the use of vasopressor drugs as an initial form of therapy in shock. These patients already have profound vasoconstriction, and vasopressors probably serve only to whip a tired horse, if you will. I do believe, however, that in cardiogenic shock, there is a place for compounds such as isoproterenol and perhaps norepinephrine because of their inotropic effect. The peripherally acting vasoconstrictors may be useful in the so-called neurogenic type of shock as a temporary measure, but I feel that they have no place in the treatment of hemorrhagic or endotoxic shock. There has been a great deal of work on the use of vasodilator drugs such as phenoxybenzamine and chlorpromazine for patients in shock. The concept here is that if one can provide better tissue perfusion by releasing the profound peripheral vasoconstriction, permanent cell damage is less likely to occur. I consider it of major importance that we think not in terms of a given arterial pressure, but in terms of that pressure required to produce adequate tissue perfusion. However, when such vasodilator drugs are employed, one must simultaneously administer blood and other fluids as necessary to fill the vascular compartments. These drugs have been quite beneficial for patients in shock whose low arterial pressure fails to respond to massive fluid administration, and who also manifest a significant elevation of venous pressure and oliguria or anuria. First, they give us a truer index of the patient's circulating blood volume, and secondly, they promote better tissue perfusion at lower arterial pressures.
What other drugs may be useful in pre-anesthetic treatment of shock?
In addition to better overall tissue perfusion, we must be concerned with prior metabolic insults such as acidosis and infection. Metabolic acidosis is a very frequent complication of shock, and sodium bicarbonate has been proven a most beneficial agent. Some of the buffer amines, such as the tris buffers, have been employed from time to time, but I believe most people feel that they offer little benefit over sodium bicarbonate. Considerable investigation has been done also on the use of massive steroid therapy to promote membrane integrity, stabilize enzyme systems, and by their inotropic action, increase cardiac output. Results with this therapy have been somewhat disappointing to many investigators, but others still feel that steroids offer a great deal of protection.
Is hyperbaric oxygen therapy useful in severe hypovolemic or septic shock?
Although early reports were enthusiastic, I believe there is little evidence that hyperbaric oxygen therapy is useful in either of these types of shock.
What other measures should be considered before administering anesthesia to the patient in shock?
One of the problems we must always consider in the patient who has suffered acute trauma is that of a full stomach. Aside from inducing vomiting, it is virtually impossible to empty the stomach completely. Therefore, it is important to assume all these patients have a full stomach and to act accordingly. The control of hematemesis is also a very difficult problem. There are those who advocate the routine use of an inflatable esophageal balloon prior to induction of anesthesia.
Do you pre-medicate the shocked patient with sedatives or belladonna drugs before anesthesia?
The patient in shock generally requires little in the way of sedation, depending, of course, on the severity of the shock. I believe the administration of opiates should be reserved for those patients who suffer extreme pain, as I mentioned earlier in connection with morphine, or who may be in congestive heart failure. Barbiturate medication is not indicated for the patient in shock. Concerning the patient in pain, there is evidence that barbiturates decrease the pain threshold and therefore worsen the situation. As for belladonna drugs, we have generally given small doses of atropine intravenously to these patients prior to induction of anesthesia, but I have yet to be convinced that this is necessary or even desirable. It is important to remember, when employing any of these drugs in the patient in shock, that administration should be intravenous and not intramuscular or subcutaneous. It is obvious that the patient in severe shock has little absorptive power. When circulatory stability is achieved, these drugs may be absorbed with some rapidity and confuse the clinical picture.
On what basis do you decide the type of anesthesia to be used?
This depends on the severity of the shock, the site of operation, and other factors. When the patient is in profound shock and coma, I might advise the surgeon to proceed without any form of anesthesia. Field block anesthesia can be employed in many instances, but again this would depend on the degree of shock and the cooperation of the patient. The same, of course, is true with other forms of regional block. In general, I feel that inhalation anesthesia is more desirable for the patient who is in moderate shock and reasonably alert.
When is spinal or epidural anesthesia the method of choice?
I am tempted to answer this question with never. I suppose there may be some suitable circumstances, although I cannot imagine when low spinal or epidural anesthesia may be indicated. Fear of using them, of course, is related to the sympathetic blockade they produce. Such blockade leads to peripheral vascular pooling and perhaps worsening of the shock. This is not comparable, however, to the use of pharmacologic vasodilators. The latter are readily reversed and can be administered by titration to any point desired.
Are some inhalation agents better than others for the patient in shock?
This again is a controversial issue among authorities, but it is my personal opinion that halothane is the general inhalation anesthetic of choice in the patient in shock. There is more and more evidence to indicate that this is so. I should state, however, that the patient in severe shock requires very little in the way of anesthesia. In many instances, sufficient analgesia and amnesia can be provided with 50% nitrous oxide in oxygen, and furthermore, any additional inhalation anesthetic might be extremely hazardous. My preference for halothane, or perhaps methoxyfluorine, is comparable to my enthusiasm in selected cases for the use of pharmacologic vasodilators. Specifically, I feel that these two halogenated agents, because of their peripheral vasodilating effect, offer us a better index to the actual blood volume of the patient and provide more adequate tissue perfusion at lower arterial pressures. There has been much experimentation in an attempt to prove or disprove this hypothesis by measuring blood flow to various organ systems before and during hypovolemia. There is evidence, for example, that during halothane anesthesia, as contrasted to cyclopropane anesthesia, the renal blood flow is not only preserved, but actually increased. Investigations in our laboratory have indicated, as illustrated, that the renal blood flow with halothane anesthesia may increase by well over 100% during hemorrhagic hypovolemia as contrasted to an effective reduction in flow during cyclopropane anesthesia. In shock patients undergoing surgery, we have also observed improvement attributable to the use of vasodilator therapy. We have here the anesthesia record of a patient who was treated in accordance with this concept. It will be noted that with the simultaneous administration of blood and vasodilators, the venous pressure was reduced to normal levels, the pulse rate decreased, and the arterial blood pressure was elevated to its normal value. Most important, immediately following the administration of chlorpromazine, general patient appearance improved markedly. The patient's skin, previously cold and clammy, became warm, dry, and pink, and his urinary output, which had been greatly reduced or absent, began to improve. Recovery was uneventful. A similar clinical picture may be noted in the second accompanying case record. Much work still needs to be done in this area, and it is now in progress at a number of institutions.
Is neurolept anesthesia or the lytic cocktail technique of parenteral anesthesia safe for the patient in shock?
The lytic cocktail concept of Laborie is similar to what we've just been discussing in that he felt the most important factor in the treatment of shock is the promotion of better tissue perfusion. For this reason, he recommended the administration of a solution containing chlorpromazine, meperidine, and promethazine. Many feel that the compound Inovar offers similar beneficial effects. The thinking of enthusiastic investigators is essentially the same as that of vasodilator advocates. It is my opinion that for the patient in rather severe shock who requires some degree of sedation, Inovar may have a place if one bears in mind that we are dealing with a very potent narcotic and adjust the dose accordingly.
Would you outline the essential measures for safe management of hemorrhagic and septic shock during anesthesia and surgery?
We might summarize the essential features in the anesthetic management of patients in hypovolemic or septic shock as follows. Assure appropriate airway management and ventilation. Establish one or more appropriate routes for intravenous infusion using the largest bore cannulae possible. Attach appropriate monitoring devices for observation of arterial and central venous pressure and for electrocardiography. Withdraw samples for blood typing and matching, blood morphologic studies, and electrolyte determinations as deemed necessary. Begin titration of blood and fluids so as to replace the deficit in blood volume. Once these initial steps have been taken, and of course a differential diagnosis has been made, arrangements should be made as necessary for whatever operative procedure may be required. For the actual anesthetic management, the preceding methods of monitoring and therapy should be maintained. The major consideration in providing the actual anesthesia for such patient concerns proper airway maintenance, provision of amnesia, analgesia, and whatever muscle relaxation may be required. This can, of course, be accomplished in many ways, and there is a wide choice of anesthetic drugs that may be used. In choosing the anesthetic drug or drugs and technique, the first and foremost consideration is to establish and maintain adequate tissue perfusion. Constant observation of the gross appearance of the patient and a correlation with the parameters being monitored are mandatory. At this point, one should also consider the necessity or desirability of employing vasoactive drugs, whether these be vasoconstrictors or vasodilators. It is obvious that in hemorrhagic shock, the most important step to be taken is toward hemostasis. This must be the prime consideration as to the time of operative intervention. In the case of septic shock, all of the foregoing steps are to be considered. In addition, the appropriate antibiotic therapy should be instituted. Also, it is in this area that one might consider the desirability of steroid therapy. I think it should be emphasized that in the treatment of hemorrhagic and septic shock, a major hazard is circulatory overload and the production of congestive failure. For this reason, central venous pressure monitoring is an important adjunct to the overall management.
How would you manage anesthesia for the parturient patient in shock due to toxemia?
I believe that for the most part, these patients are to be managed as outlined in the previous answer. Correction of the underlying cause of this shock is again the primary consideration. Puerperal sepsis is treated much like any other form of septic shock, and likewise concealed uterine hemorrhagic hypovolemia of any other cause.
Thank you, Dr. Fabian. Anesthesia Rounds is presented to clinicians in the field of anesthesiology by Airst Laboratories. Anesthesia Rounds, a series of discussions of clinical problems facing the anesthesiologist. Anesthesia Rounds is presented as a service to clinicians in the field of anesthesiology by Airst Laboratories. In this interview, Dr. John B. Dillon, Chief of Surgery Anesthesia, University of California, Los Angeles School of Medicine, discusses the purposes and functioning of an outpatient surgical service and the responsibilities associated with anesthetic management of the outpatient. Among the questions that Dr. Dillon will consider are the range of procedures performed, the range of anesthetic techniques employed, criteria for patient selection, typical schedules in an outpatient surgical unit. Dr. Dillon, what is the purpose and special value of an outpatient surgical unit?
The unit is designed primarily for minor surgical and diagnostic procedures. These procedures may be performed either under local or general anesthesia. The patient is received no earlier than 8 o'clock in the morning and returns home no later than 5 o'clock in the afternoon. If something occurs that requires the patient to be retained, he may be admitted to the hospital overnight. This, however, has seldom happened.
What range of anesthetic techniques is provided for the outpatient?
It could be anything from a local anesthetic to a spinal, anything from mild sedation to relatively deep anesthesia, depending upon the patient's requirements and physical state. About half our patients receive general anesthesia.
About what percentage of the overall anesthesia delivered here at UCLA is to the outpatient?
About 7.5% to 10% of our patients are managed in this way.
What advantages are associated with outpatient anesthetic management?
The major advantages to the patients are that he is not as financially or psychologically disrupted as when he is admitted to a hospital. It is our opinion, based upon considerable experience, that if one manages such a program properly, the threat to the patient's physical welfare is negligible. In fact, in our hands, such a threat has not existed, and patients have been saved anywhere from $50 to $100 of out-of-pocket expense. And in the case of children, this program has spared them the psychological trauma of being away from their homes and the families for a significant period.
What types of surgery are most likely to be represented in the outpatient group?
We now do a large number of superficial plastic procedures, many urological procedures. We do a considerable amount of ophthalmological surgery, examinations and related procedures of this type, particularly in children with glaucoma and those with congenital defects, of which there are a wide variety.
A wide variety of eye problems?
Yes, including, as already mentioned, glaucoma and congenital cataracts, as well as strabismus. We also do a great number of D's and C's. In fact, almost all our routine D's and C's are now done on an outpatient basis. We do some minor general surgical procedures. A fair number of infant hernias have been corrected on an outpatient basis. Procedure appears to be very satisfactory from the points of view of the mother as well as the child.
Herniorrhaphies?
Yes.
What other kinds of general surgical procedures could be performed in this way?
One can think of a large number of minor rectal procedures that could be performed in this way, although in a hospital of this type, one doesn't see this sort of patient too often. Frequently, of course, the general surgeon will do a great deal of what we might consider as plastic types of procedures. In private practice, these procedures are handled by the general surgeon more often than they might be by a plastic surgeon.
Do you believe TNA should be done?
We do not consider a tonsillectomy and adenoidectomy appropriate procedure for outpatient management. We have never done one of these on an outpatient basis. There is more postoperative bleeding than we will accept as a minimal risk.
What about orthopedic procedures?
Well, of course, we do closed reductions of fractures and dislocations, but on an emergency rather than an elective basis. These are performed as an outpatient procedures, basically. At least no more time is spent in the house than is necessary for the patient to recover completely from anesthesia.
What other procedures or types of procedures have been done on an outpatient basis elsewhere that you know of that might be done here sometime in the future?
I think any procedure that does not require the patient's admission to a hospital for surgical reasons can be done perfectly satisfactorily as an outpatient, insofar as anesthesia is concerned. My point of view is that the problem is not one of anesthesia, it is one of surgery. The patient who, for surgical reasons, must be admitted to the hospital is not suitable for outpatient procedures, obviously.
Well then, is there some rule of thumb to include or exclude the patient from this category?
I think that any procedure that involves a significant loss of blood that results in physiological or emotional disturbances to the patient, or that requires lengthy or intensive postoperative care for a surgical reason, such as the management of drains, would not be a suitable procedure for an outpatient unit. Anything that requires the patient to be immobilized for any period of time, that is, to be in bed for 24 hours or so, would not be suitable.
Are there general categories of patients for whom ambulatory care is not indicated, using, for instance, such criteria as age and sex?
No, age and sex per se are not criteria for selecting patients. As a matter of fact, children are in many ways the very patients who are most suitable for outpatient procedures, because they are the ones who are most frequently disturbed by dislocation. It is the surgical procedure itself that is the controlling factor in our opinion.
Do you wish to say anything about such a criterion as the patient's educational level?
Obviously, any outpatient surgery is done under controlled conditions. The patient is supervised both in the immediate pre-surgical period. For example, during the morning, it is seen to it that the patient has had nothing to eat, and postoperatively in the sense that the patient is supervised as he is returning home. Someone among his relations or friends has to be sufficiently well educated to understand directions. So far as the educational capacity of the patient himself is concerned, this is obviously, I think, of secondary importance.
What about the patient's general health?
So far as physical standards are concerned, these patients obviously are all selected on an elective or semi-elective basis. No patient who has a major surgical requirement is accepted as a surgical outpatient. As indicated earlier, any patient who needs hospitalization would not be considered, with a very few exceptions. We do occasionally admit patients through the outpatient service when there is an acute shortage of inpatient beds, and this has worked out quite well from the patient's point of view. But we would not accept, for instance, patients for minor surgery who are suffering from severe diabetes or vascular problems or severe anemia or anything of similar nature. The patient has to be in what we would consider in the general area of good physical condition to undergo a minor surgical procedure.
Are there limitations related to the acceptable severity or duration of surgery?
Well, about 99% of our surgical procedures will last certainly no more than an hour or an hour and a half. And during that period, of course, most of the time is not devoted to the actual surgery, but to prepping and draping, suturing, and similar activities. Time is really not such a great problem. Generally speaking, operative time is less than an hour. The significance of the operative time has something to do with the anesthesia, of course. In general, the longer the patient is under anesthesia, the longer it takes for him to recover if a general anesthetic is used. If it is a block anesthetic, it doesn't make any difference with respect to recovery as long as the effective time of the block is not exceeded. These are matters that are controlled by experience and judgment.
Since operative time is related to recovery time, what might be a maximum operative time?
I think the longest time in our experience was about 3 hours. most of these few cases occurring during the first year of the program and being the result of mistakes in selection. I think that around 2 hours would be the longest time we would now expect any procedure to last. In our view, it is extremely important that the maximum anticipated recovery period should be no longer than 3 hours.
On what other basis would one select or reject patients? Would anticipated bleeding be one such criterion?
Oh, yes. Any surgical procedure that we know is statistically or historically associated with complications is not done on an outpatient basis. In other words, we wouldn't presume to do, for instance, a cavernous hemangioma as an outpatient. And as I have mentioned, T's and A's.
Who establishes the guidelines for the selection of patients? Need the hospital executive committee approve them?
No, these guidelines were set up entirely by the anesthesia service, and we determine whether the patient will be accepted and on what kind of a patient will be operated on and under what circumstances he'll be operated on. The surgeons follow these guidelines because they were designed primarily for the patient's protection. One cannot argue with the concept of patient safety. That is what we're after within very strict limits.
Is there a standard examining procedure with respect to admission of the patient?
The patient is seen by his physician sometime within a week prior to the contemplated procedure. The history is taken and a physical is done just as if he were having the procedure performed on an inpatient basis. He then goes to a laboratory, usually the university laboratory, but perhaps a commercial laboratory in the community, for a complete blood test and urinalysis. The results are referred to the surgeon. The surgeon schedules the cases in the regular way. The patient's record is then taken to the outpatient department the day before surgery and is checked by the outpatient recovery room nurse to see that it is complete in substance. If, for instance, the laboratory report is not there, the surgeon is notified and the admission corrected or the case canceled. The patient comes into the hospital in the morning of the day of the procedure as scheduled around 8 o'clock. He is seen by the surgeon and anesthesiologist. His record is checked again. A re-examination of the patient is made. His history is reviewed. Whatever appears to be pertinent is rechecked. And then, if everything is satisfactory, the patient is premedicated. If anything is out of order, the case is canceled. And there is no question about this.
With respect to orienting the patient and the instructions delivered to him, in what manner and with whom is he asked to come to the hospital on the day of surgery?
A printed instruction sheet is given to the patient by the surgeon. The patient may be accompanied to the hospital or he may come in by himself. But no patient is ever released until someone comes to get him. That is, some responsible adult, regardless of whether the patient is a child or adult.
Are consent forms signed?
Oh, yes. We use the usual consent forms.
And in the next step that you referred to, preoperative testing, are a blood test and urinalysis the standard procedures you require?
Basically, of course, if the patient should have a chest film or an EKG or blood chemistry because of some other condition he has, these are all done.
Blood and urine testing are the only routine examinations?
Yes, however, I dislike the term routine. The patient has whatever examinations are thought to be proper, although blood and urine studies have an historical significance and are always considered routine.
What are the preoperative requirements with respect to fasting?
That patients have nothing to eat from midnight of the day before. If the patient is a very small infant, we'll accept the taking of clear liquids up till 2 or 3 o'clock in the morning. This has never been a real problem with us. I think that in the last year we have perhaps 2 or 3 patients who have been given an inappropriate feeding. These cases are simply canceled.
How does this apply to older children? Also nothing by mouth from midnight the night before?
Yes, if they're old enough so that feeding is not a major problem. Infants can have their last feeding about 2 or 3 o'clock in the morning because ordinarily they empty their stomachs very quickly.
How is the significance of the fast explained to the patient?
Well, I think most patients realize that they are not supposed to eat before surgery. This has become part of our cultural heritage over the last 100 years or so. That one ordinarily does not have anything to eat or drink before he's going to have an anesthetic. In any case, this is all discussed with them by the surgeon. The incidence of preoperative ingestion of food or fluids has been so small as to not be of any statistical significance in our patients.
Are patients seen immediately, preoperatively by the surgeon?
They may or may not be seen by the surgeon, depending upon when they were last seen by him.
When do they meet with the anesthesiologist?
The anesthesiology service is notified as soon as the patient arrives in the outpatient clinic. We then send someone up to see him within a few minutes.
What of note occurs at that time?
The patient is interviewed by the anesthesiologist to determine whether any physical examination or detailed history is indicated. The anesthesiologist is basically concerned with determining whether there is any indication for canceling the case. If the patient is in good condition and there are no possible interdicting problems, the examination and history taking will be minimal. The patient's temperature is always taken, something of particular significance in children because they are prone to acute respiratory and exanthematous diseases. The same general care is given to these patients as is given to inpatients.
What other steps are taken prior to surgery?
None that aren't standard inpatient routine. The patient is gowned, put on a proper conveying vehicle, premedicated, and then at a proper time taken to the operating room.
Where is he physically before surgery?
He's in an outpatient recovery room area. He is both admitted through and discharged from there.
Is the outpatient area contiguous to the operating theater?
Not now. It will be when we are finished our new construction, but it is within a reasonable distance.
What specifically can be said about preoperative medication for the outpatient?
Preoperative medication is, of course, dependent upon what the patient is going to have done, what kind of anesthesia is going to be used, and his general requirements. We find that a great deal of premedication is unnecessary. We frequently give our premedication intravenously, which assures its prompt action in a predictable time and in a predictable manner.
Which ones might one use routinely? For instance, do you use short-acting barbiturates if there is notable apprehension on the part of the patient?
Yes, or we may use some tranquilizer intravenously. Generally, this is not a great problem because these patients are carefully selected by the surgeon. They are patients who want to have their procedures done in this way, or if the patient is a child, he will behave no differently in this environment than he would in any other environment. As a matter of fact, many of our patients are managed many times on an outpatient basis. We have given some children as many as 35 or 40 anesthetics on this basis. This is rather unusual, but I am sure it will become more common because we now have types of anesthetic agents that, although not yet commonly available, make this type of management not only practical but acceptable.
What serial procedures are you referring to?
Primarily, these are ophthalmological procedures on children who undergo radiation therapy for retinoblastoma or brain tumors and for whom frequent anesthesia is necessary, both for therapy and studies that are incident to it. Also, we repeatedly manage children who have chronic urinary problems. When we speak about managing children perhaps once a month in the case of urological problems, or much more often in the case of radiation therapy, we are talking of saving literally thousands of dollars for the patients.
Are you in the habit of using atropine in children?
We never give atropine to a conscious patient. I think it's inhumane and unnecessary. The belladonna drugs can be given intravenously at the time of anesthesia. They work very quickly, and there is no sense in distressing a patient by the use of this type of agent preoperatively.
Is an intravenous always started?
We always start an intravenous on all patients to whom we give an anesthetic. This would not be true for the patient being given only a local anesthetic and being managed completely by the surgeon. When we do provide an anesthetic service for the patient, an IV is always started. This is the route for giving routine and emergency drugs in case that becomes necessary. And it is the route for giving fluids the patient has not had for the past numbers of hours and will not have for the next few hours. The cost of establishing an IV route and giving fluids is so small in terms of its contribution to the patient's general welfare that neglecting to do so, in my opinion, is inexcusable.
Is fluid imbalance a common problem?
No, Class 1 patients usually can tolerate an extracellular fluid and electrolyte deficit without harm. But since we can do him some good, why subject the patient to fluid imbalance? I can see no justification for it. The IV route should be immediately available for responding to a surgical emergency.
What percent of the anesthetics did you say are local and what percent general?
About 50% of the anesthetics given to outpatients are local, and about 50% are general.
What local technique is used most often and why?
This decision is entirely up to the surgeon. Usually, it will be just a field block or local area block. We are not directly involved in these cases. The outpatient surgical unit just provides a place outside his office in which the surgeon can do a minor procedure.
He provides the anesthesia himself.
Oh yes, under these circumstances, we don't impose our services. We only function when the surgeon asks us to. And he only asks for our services when general or regional anesthesia is indicated. We do spinals and epidurals on an outpatient basis, but not very often.
Which spinals are done and what agents are used?
We use tetracaine for all our spinals. We would use perhaps 3 to 5 milligrams for some rectal procedures, as a rule. And if this were so, it would be done with a number 25 needle. The pertinent question, however, is, does a patient who has a spinal anesthetic necessarily have to be bedridden? We don't feel that he does. If he has recovered motor function and is able to stand and walk, he has met our criteria for being sufficiently recovered to be taken home. We frequently find under these circumstances that urinary retention and all other problems so commonly associated with spinals do not occur.
With respect to generals, I presume most anesthesia is by inhalation.
Well, some of it is by inhalation and some of it intravenous anesthesia. It depends again on what is going to be done. Frequently, we use a little intravenous combined with inhalation. On the patients that I previously mentioned, those that have a very large number of anesthetics given to them, we use a new intravenous compound that is not yet readily available, but which we hope will soon be.
What new agent are you referring to?
It's called ketamine. It is a very unusual anesthetic, still in an investigational stage, that we have had the privilege of using.
Do you ever use open drop methods with children?
No, we don't believe that there is any indication for open drop anesthesia in a hospital environment.
What about the inhalation agents you use here? Which ones are you most likely to use and in what combinations?
We use nitrous oxide and oxygen in association with intravenous anesthesia. We use nitrous oxide and oxygen halothane under some circumstances. We do not use any explosive anesthetics in this institution.
You don't use cyclopropane at all?
No. We haven't used it in approximately 5 years. Don't even have a bottle of it in the hospital. We see no need for it and believe that it should be abolished from use.
When do you use nitrous oxide and oxygen?
We use it occasionally in very short procedures, for instance, the removal of a pin from a finger in an orthopedic patient. We do a great deal of reconstructive orthopedics here. Removing a pin from a finger may take a minute or a minute and a half, long enough to make a small incision in the skin and extract the pin with pliers. This we may do under nitrous oxide and oxygen, and it works very well. The extraction of a single tooth, for example, performed for some special plastic surgical procedure, may be done under nitrous oxide and oxygen.
What about muscle relaxants? When do you use them and which ones do you use?
Generally speaking, if we have to use a muscle relaxant, we'll use a short-acting one, a depolarizer such as succinyl choline. However, we do not hesitate to use curare. I think there is too much concern with anesthetic and ancillary agents. If the patient reacts inappropriately to the anesthetic or other agent, which I think has happened about twice in the last 1,000 cases, then he is hospitalized. If he doesn't react inappropriately, then it is perfectly safe for him to go home.
Returning to muscle relaxants, have you had any problem with muscle pain or fasciculation when using succinyl choline?
No, we have found that the incidence and intensity of fasciculation is related to its speed of injection. Experience has taught us that when you give succinyl choline very slowly, the incidence of severe fasciculation and muscle pain is negligible. But if it is given rapidly and in fairly large quantity, fasciculations are pronounced.
Returning to the subject of intravenous general anesthesia, what agents would you recommend?
We use a thiobarbiturate, just as everyone else does. There's nothing sacred or secret about this or any other type of anesthetic technique we use. It's the intensity and duration of the anesthetic combined with the intensity and duration of the surgery that determine what's feasible on an outpatient basis. One knows that a great many anesthetics are given in dentists and private practitioners' office. This isn't discussed very often or openly, but nevertheless, these are the facts. I feel free to say that most of these patients are provided far poorer control than we exercise here.
Do you find some difficulty with intravenous anesthesia in controlling the airway or the depth of anesthesia?
No. A patient is managed identically as if he were under any other general anesthetic. There is no difference at all.
You don't find that there is a prolonged recovery time?
No, I am delivering the kind of anesthesia to the kind of patient who neither requires a long nor, generally speaking, a profound anesthetic. Certainly not a profound anesthetic over a long period. If that were necessary, the patient would be hospitalized. This happens about 4 or 5 times a year because of some unforeseen surgical problem.
Dr. Dillon, would you describe the anesthetic technique used for intraoral or facial surgery?
Depends largely on what the surgery is for. As I said, we don't do many intraoral cases at the moment because our dental service is not developed. But I can say that we would use endotracheal intubation. We do a lot of dermabrasions under sedation and usually intravenous sedation. Some local anesthetic may be put into the area unless the procedure is very involved because the surgeons like it. They think it controls bleeding.
Would you elucidate that point, please?
Surgeons like a little epinephrine in dilute local anesthesia. With dermabrating or some similar procedure, we would do nothing more to the patient. We wouldn't even use an airway if ventilation were adequate.
The local technique you speak of is infiltration.
Yes, but under these circumstances, the patient would be additionally sedated with an intravenous thiobarbiturate.
What anesthetic technique do you use for herniorrhaphy?
Well, it would probably be done under halothane.
What would be your approach to the removal of an exostosis on hand or foot?
If it were a large one, the probabilities are that it would not be done on an outpatient basis because they are extremely painful postoperatively. If we're on the hand, we might do a regional block of a type consistent with the procedure. If we're on the foot, we might do a unilateral spinal or epidural block. But these are usually so painful that the patients are debilitated for several days. I think it would be very uncommon for these patients to come into the outpatient service.
What is the general pattern of postoperative management, and what is available in the way of recovery facilities?
We have an outpatient recovery room accommodating approximately 6 patients at a time. We always have 1 fully trained nurse, frequently 2, and as many ancillary personnel as they may need, usually an aide or an attendant. After the procedure, the patient is returned to this facility by the anesthesiologist. We attempt, insofar as possible, to have the patient at a very light level of anesthesia, whether he has been under a general or a regional anesthetic. Sufficient time is provided before returning him to the recovery room nurse to assure that his condition is stable. He is monitored and undergoes recovery in the usual way.
Is anyone ever sent home unattended?
No, never. This is an absolute requirement. If the patient is not attended, he is not discharged.
What about a companion at home? It may happen that there is someone to take him home, but that there isn't anyone to remain with him.
This has never been a problem to our knowledge. Everything is conceivable, but one has to remember that this is a planned procedure. I suppose a patient could be taken home and then left alone when somebody went out to get some groceries. But he would be perfectly safe at home. He was competent before he was discharged from the hospital.
Are there any elements in your procedure here that may lead to difficulty if adopted out of context by another institution? Is there any point here that might need clarification?
A service such as this must be dedicated in every way to patient safety, and one has to take this point of view from the very outset. We believe that this kind of program has to be under the control of the anesthesiologist to the extent that he is involved. When our services are involved, we set the rules, and these rules are scrupulously attended to. We have found that the surgeons are happy to have such rules to abide by.
Have you ever had any of your guidelines abrogated?
Never, because the patient wouldn't receive an anesthetic. This, of course, is the controlling factor. We would simply refuse to accept the case on the basis of what we found preoperatively.
What kinds of unanticipated anesthetic problems have you seen since the start of the program? And how many patients have been managed by the outpatient service?
It's a fair number of patients now, probably over 4,000. We got into all kinds of little problems when we first started. We accepted a few inappropriate patients. but we never had any serious complications. We have never had a fatality in the program.
What are the criteria for establishing such a service? What would be the minimum criteria with respect to such factors as staffing and the size of facility?
I don't think these factors are really the controlling ones. The controlling elements are the surgeons on the service and the kinds of patients you're dealing with, cooperative or uncooperative, and the anesthesiologist.
Would it be applicable in, say, a small-town general hospital?
Yes, it would be no more inapplicable there than anywhere else. Again, it would be a matter of attitude rather than a matter of place. This, I think, is the thing which one has to keep clearly in mind. This is an attitudinal problem, not a problem of location or size of community or size of hospital. The patients must be selected carefully, and if the surgeon and anesthesiologist have the right attitudes, they will take care of the selection.
Then capacity to select and to adhere to the standards for selection are the essential characteristics of such a program.
That's right. Patient selection is the secret, and this requires cooperation between surgeons and anesthesiologists. It's certainly a bed-saving procedure. We believe we've saved about 1,000 bed days a year, and we've saved patients on the average of between $75 and $100. The principal problem, actually, has been the insurance company. Many insurance companies feel that patients should be hospitalized at least 18 hours before benefits are to be paid. They feel there may be, otherwise, some patient exploitation. I think insurance companies will ultimately discover that this is a short-sighted attitude and will be willing to pay for services rendered to patients on an outpatient basis.
What are the chances of complications occurring after the patient has been discharged?
We have not run into this problem. I can't say that no complications have ever occurred. That would be impossible to know. But we have not heard of such an occurrence from surgeons or the patients themselves.
Thank you very much, Dr. Dillon. Anesthesia Rounds is presented as a service to clinicians in the field of anesthesiology by Airst Laboratories.